Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for December 13th, 2023. Thank you for joining us this month. Our presenter today is Amanda Nelson. Dr. Nelson is an associate professor of medicine in the UNC Chapel Hill Department of Medicine's Division of Rheumatology, Allergy, and Immunology. Dr. Nelson is a board-certified internist and rheumatologist with a master's in clinical research and epidemiology. She spends 1 day per week in clinic, divided between general rheumatology and musculoskeletal ultrasound, and is involved in fellow education and mentoring. Her research is focused on a variety of aspects of imaging in osteoarthritis, or OA, including the contribution of bone shape to OA risk, novel methodologies for analysis of large and complex data sets, including machine learning, and assessment of whole body burden of OA. Dr. Nelson is co-PI of the Johnston County OA Project, a 30-year community-based prospective cohort of OA, multiple chronic conditions, pain, and disability in Black and white men and women, in its new enrollment phase, the Johnston County Health Study. She is also director of the Phenotyping and Precision Medicine Resource Core of the UNC Core Center for Clinical Research and medical director of the Osteoarthritis Action Alliance. The title of today's presentation is Multi-Joint Osteoarthritis.
And mortality, which I'll also show you. And clinical trials to date have not particularly well accounted for, or even at all, for multi-joint OA or for multi-site pain. We'll talk about that. And there's a lot of ongoing study in this area, fortunately. So this was really my first research question. It's one of my favorite topics. And how it came about was that I was starting my journey as an osteoarthritis researcher and realized that while most of the papers I was reading were about a single knee, perhaps a right knee or an index knee, which is often how it's termed, like a knee under study, I noticed that all of my clinic patients had osteoarthritis in multiple joints. They were telling me about their hands and their back and their feet, and that really was not a focus of the research. So I was fortunate to get an early Career Development Award from the Rheumatology Research Foundation, which I am eternally grateful for, that helped to fund some of this initial research that I'll show, and sort of my lifelong interest in this area. So as Katie mentioned, I am co-PI with Yvonne Golightly of the Johnston County Osteoarthritis Study, which is a prospective population-based cohort study. This was really just any community living adult over age 45 who was Black, white, man, or woman. It started in 1990 and over time has involved more than 4,000 unique individuals with about 30 years now of follow-up, and follow-up visits about every 5 years as shown in the timeline here. You don't have to read that, but it just shows the various waves of data collection over the 30 years. And some of the information I'll show comes from that. In addition, as that original cohort has reduced in number due to loss to follow-up, but primarily just due to death and attrition, we've begun enrolling a new cohort called the Johnston County Health Study that started in 2019. It builds on the strengths of the parent project, including the population-based nature, the community sort of health and diversity. It includes younger individuals beginning at 35 years of age instead of 45, and it has also included Hispanic individuals, which were not part of the original cohort because of their very low representation in Johnston County, North Carolina in 1990, and their much higher representation now. So in order to be representative of our county, that has been a change in the enrollment. And all of our materials are also available in Spanish, so individuals can speak Spanish or English to be enrolled. And we have a logo in both languages. Some of the information we've been able to glean from this population-based data set over time have included lifetime risk of symptomatic OA. So this is a statistical method of estimating the risk of developing a condition by age 85. And that turned out to be about 40% for hand osteoarthritis. That was higher among women and whites, so not quite half, but almost. About a quarter of people will go on to develop hip osteoarthritis with no differences by the risk factors we studied. And it kind of in between 45% for knee osteoarthritis, that was over 50% for individuals with obesity or with prior history of injury. So by site, these are quite frequent, but again, we need to look at them in combination. What we do have from the Johnston County data and now from JoCo HS are radiographs and questionnaire data for multiple body sites. So we don't ask just about knees or just about hips. We ask at every visit about multiple joints, and you can see just a representation of which joints we ask about at which visits. So we have these, across time. We have various measures at the different joint sites. So we really are in a unique position to look at multiple joint osteoarthritis. This is one of the first investigations I did in this area to kind of look at, who gets multiple joint osteoarthritis and where do they get it? So these are mutually exclusive categories. So each little box, and you don't have to read them, is a different site or combination of sites involved with osteoarthritis, and they're all color-coded in the bars, so everybody matches up to 100%. No OA is also in there. So this is everybody in the population-based cohort, whether they had osteoarthritis or didn't, and where in their body they had it. And these are radiographic osteoarthritis, so these are defined by images. And you can see on the top, the proportion among our Black participants compared to the proportion among our white participants on the bottom. Oops, sorry. There's a similar graphic by sex. And we can see, just as an example, this teal colored bar is much bigger among the Black participants than the white participants, and that turns out to be knee plus spine OA, so 2 large joint sites involved with osteoarthritis. And over here is patellofemoral and tibiofemoral and spine, which again is much larger proportion of sites among the African American participants. If we look at it in a different way and say, well, which patterns are more common in which groups, then we can see here our adjusted odds ratio, so less common ones are down below. So this is Black participants compared to white participants are much, much less likely to have any phenotype that includes the hand. Hand, hip, and spine, hand and spine, hand only, hand, knee, and spine, hand, knee, and hip are all much less common among Black participants than white. Versus over here are large joint phenotypes, hip and spine, hip and knee, hip only, knee and spine, are more common among Black participants. So what this tells us is that, when we often think about generalized osteoarthritis in a clinical setting, we think about hand and something else. So anyone with a rheumatology background, sports medicine, orthopedics, you sort of say, well, it's hand and knee or hand and something else. And that's kind of how it's usually understood, which is part of the problem with not having a clear definition, because we can see here that Black participants don't have hand, but are still quite likely to have multiple joint involved, but in their lower extremity and their weight-bearing joints. So that's important for capturing people who are affected by the burden of this condition. This is the same thing for symptomatic osteoarthritis. So first was just radiographic. This is symptoms and radiographic changes in the same joint site. In the box is knee only, so you can see that Black participants were more likely than white participants to have symptomatic knee osteoarthritis alone, and we had shown that in prior work. But more importantly, they were much less likely to have combinations that included hand, just like you saw in the radiographic OA. So these are much less than 1, indicating that those are infrequent. So hand not being part of this construct of multiple joint OA in our Black participants. So all of this kind of brought us to say, well, why don't we know what generalized OA is, and what is it defined in the literature as, and how can we learn about ways other groups have looked at this and how we might compare across studies? So we undertook a systematic review that's published at the reference at the bottom, and this looked at multiple different studies to try to identify how they had defined generalized OA or multi-joint OA or OA in multiple sites. We had to use a lot of different search terms to capture all of that. The references are there. You can see there's a lot of them. And there were sort of 10 that we could condense this into. And a lot of these were, again, hand and a large joint, more than a certain number of joints, more than 2, more than 3, more than 5, nodal changes in the hands and another joint, these kinds of things. And so we looked at all of those 10 definitions that we pulled from the literature in the Johnston County population in a cross-sectional way to assess how common those definitions were within our population-based study. And you can see that for the vast majority, they're really quite common. They're all kind of in the double digits, pretty frequent both for radiographic, less so for symptomatic, but still up there, except for this one bilateral knees and spine, which is fairly rare. But across the board, you can see that multi-joint OA, regardless of definition, but variable over definition, is common in the population. Then we looked at health outcomes that might be relevant to a condition affecting more than one site, right? So we don't really want to just look at knee function like we might look at with the WOMAC, or just look at pain in one site. We really want to think about overall health and how having multiple joint osteoarthritis might impact these more general health measures. So this is just an example. Again, a publication is cited. All 10 definitions down the far left column. Whether or not that definition is met is the yes or no. And then how many people reported fair or poor health is this first one in a box. So you can see that if they met criteria for multi-joint osteoarthritis definition 1, more people than those who didn't had general health being in the fair or poor category versus good or excellent. They also had worse physical function, and this is true for both radiographic and for symptomatic OA. And I've just put a couple of these little bars on here to help align. So for multiple joint osteoarthritis 4, same pattern, worse general health, worse function, regardless of whether it's radiographic only or symptomatic, although the difference is more marked in the symptomatic group, and true for many of these definitions. We then wanted to look at that in our new cohort. So we wanted to see if these patterns held true for these younger, more diverse individuals that we're enrolling now versus people that we enrolled 10 years ago. So in the first 500 people that were enrolled in the Johnston County Health Study, we looked at these same definitions. This was work done by one of our very brilliant medical residents who's now a rheumatology fellow. And we saw that almost a quarter had 2 or more lower body sites involved in this group. And again, to recall, these are population-based studies. So these are not people coming to a doctor. These are not people with symptoms or a diagnosis. These are just people out in the community who are screened for these things and are discovered to have multiple lower body joint sites. So it's obviously very common. 19% had 3 or more joint sites that might include hands. Most of them were symptomatic in at least one of the joint sites. And you can just see kind of the demographics here. This is also impressed by Sherwin-Novin at the Journal of Rheumatology. So these are not isolated to an older cohort that was enrolled many years ago. This is an ongoing and active problem. Previously, I had also been interested just in the separation between radiographs and symptoms. And this comes up a lot. And we actually have an abstract under review at ORCE for this year about this. Is it the symptoms? Is it the radiographic osteoarthritis? Or is it the combination of the two? What's driving this issue? And so back when, many years ago, 10 years ago, I did a factor analysis to try to see were some of the joints going to group together based on radiographic features, or were symptoms going to group with their joint, or were they going to group with other joints, or were some joints going to group together, and how was that going to work? And it's really very interesting to see that the IP joints, so the little knuckles of the fingers, and the CMC, which is the base of the thumb, which are very commonly involved with osteoarthritis, all grouped together and had a very low correlation with function by the health assessment questionnaire and by gait speed. So these are just general physical function measures and how they correlate. And the 0.2 is a pretty low correlation. The metacarpal phalangeal joint, which is the larger knuckle in the hand that's more often involved in rheumatoid arthritis than in osteoarthritis, had a much lower correlation there, but it's still grouped together and separately from the other hand joints. Knee is next, hip, you kind of see this pattern here, and spine. But all of the symptoms from every site, so hand symptoms in all 3 of these hand sites, knee symptoms, hip symptoms, spine symptoms, all grouped onto a separate factor called the symptom factor here, rather than with the joint they're involved with. And that symptom factor was really strongly correlated with hack and gait speed compared to all of the other joint sites. So it suggests that it's really the symptoms driving things, which makes sense to us as clinicians, patients, people that work with individuals with arthritis, but is not generally how it's looked at in the research. There have been other studies of multi-site pain that I want to bring your attention to. You can look at these. I put the PubMed Central IDs because those are publicly available. Lisa Carlesso and the group noted that severity of knee pain and the bilaterality of knee pain increased risk of having widespread pain. So knee pain, regardless of what else is going on, over time, those people were more likely to develop widespread pain, which just means pain in multiple sites like we've been talking about. Individuals who were at risk or already had knee osteoarthritis who developed new knee pain also developed more sites of pain outside the knee. And chronic multiple joint pain, regardless of whether there's OA or whatever, is quite frequent among older individuals in general. Many of them do have multi-joint OA, but some have low back pain, weakness, obesity, other comorbid conditions that are associated with their chronic multiple site pain. We've looked at biomarkers of multi-joint OA. I put the reference again for that review because it sort of summarizes everything fairly briefly. But biomarkers in osteoarthritis research the goal has always been to kind of use it for a joint, right? Does this knee progress in its osteoarthritis? But if we are drawing a biomarker from serum or pulling it from urine, that by its very nature is a systemic marker, right? So it's going to assess changes in collagen, changes in cartilage, changes in synovium from any joint in the body because we're pulling it from a systemic marker. And so if we just think about it in relation to one index joint, we're likely not to see associations. And so we really have to at least account for those other joints or use these as markers of burden of osteoarthritis. Joint counts done by various methods. So just for example, you could count up joints that are involved, hand, knee, hip. Those could be bilateral or unilateral. You could count up the Kellgren-Lawrence grade, the global radiographic grade for different joints. You could count up the symptomatic grades, 0, none, mild, moderate, severe, 0, 1, 2, 3, and add all of those together. So you can sort of get a burden score from a variety of different ways. But those kinds of counts have been associated with several different biomarkers listed here. CTX2 is about kind of calcified cartilage, COMP is about cartilage, MMP3 is a cartilage marker breakdown, and hyaluronic acid is often associated with synovitis. There's also a protective biomarker. So if those levels are high, you're less likely to have osteoarthritis. And those all associate with burden. So that's really interesting and important. I mentioned other outcomes. So we talked a little bit about physical function and general health. We might think about falls, right? So if people have multiple joints involved in their lower extremity, maybe they're more likely to fall. And so one of our fellows several years ago now looked at this to see how many lower extremity joints individuals had in Johnston County and whether they then had an increased risk of falling. And this is the table from this paper, citation at the bottom. And you can see that people with no symptomatic osteoarthritis joints in their lower extremities were the reference group. If they had one joint, they were 50% more likely to fall, 2 joints, 75%, 3 to 4 joints, 85%. And this was adjusted for known risk factors for falling, including race, sex, age, BMI, having previous falls, having other comorbid conditions, and using narcotic medications, which is also associated with falling. So seems to be important for other outcomes as well and really needs to be considered in those settings. Future directions, right? So we want to figure out what this is all about and how to impact this. And another area, we talked about biomarkers as being systemic markers of osteoarthritis. You can also think about things in the gut. So the microbiome, or what's going on in your gut and the bacteria in your gut, has been a really interesting research area in a variety of inflammatory diseases, right? Inflammatory bowel disease, diabetes, a lot of different things. And it has been looked at particularly in our group in association with osteoarthritis, particularly in obesity, but in general. And so we see that a marker of intestinal permeability, which is this lipopolysaccharide, big long word here, was associated with having osteoarthritis in obese adults. And that's interesting, right? So why would that be? It wasn't really the bacteria in the gut, it was the intestinal permeability. We also looked at plasma microbiome and how that might associate with obesity-related osteoarthritis. So one is in stool, one is in plasma. We can look at this in a variety of different body fluids. So we actually have an ongoing study right now specifically about intestinal permeability and multi-joint osteoarthritis in humans, in the study I've already shown you, but also in dogs. So if you think about any dog you've had, if you're a dog person, they often get arthritis as they get older, and many times they get multiple joint osteoarthritis. So dogs are a really interesting natural model of OA, particularly MJOA. And our hope is that if we can discover some unique features about MJOA and potentially intestinal permeability, that we may be able to design trials, perhaps in companion dogs, that would benefit both the dogs and their people who have multiple joint osteoarthritis. So this is an ongoing funded NIH study. Duncan LaSalle is at NC State. He's walking the dog in the picture and is my co-PI on that study, which we're very excited about. So we're going to go back to the summary points. I'm going to make sure I've emphasized everything I want to, and then we'll go to questions. So again, if you hear the term generalized osteoarthritis, just know that that doesn't really tell you much. It probably means hand and something else involved, but unless you have a statement that says generalized OA as defined by radiographic osteoarthritis and the IPs and the CMC and knee OA or something, then you really don't know what that author or that paper or that guideline means by the term generalized osteoarthritis, because there is no accepted definition. And as I showed you, there's at least 10 used in the literature. Multiple joint osteoarthritis seems to me to be a more descriptive term, more transparent, plus a clear description. So multiple joint osteoarthritis characterized by involvement of the hand, knee, and hip or something. You just want to know what you're talking about and what's being considered. Multiple joint osteoarthritis is frequent. I've shown you that in a variety of ways. It imposes a substantial burden on patients, and it exhibits differences by sex, which I didn't get into too much, but they're there, race, ethnicity, other features. So it's not a homogeneous entity by any means. The burden is apparent in associations with key outcomes of general health, function, falls, mortality. People do worse if they have a higher burden of osteoarthritis. Unfortunately, to date, clinical trials have not done a good job of accounting for multi-joint OA or multi-site pain. That's beginning to change. Some clinical trials now are either excluding individuals with widespread pain, which may not be the best approach, or focusing on people who can differentiate one site from another. So they might ask questions about how bad knee pain is versus how bad pain in the other knee or hips or other sites might be, to figure out if they're going to be able to measure an improvement based on what other intervention that they're proposing. So it is starting to be thought about, although again, it's not the accepted way of doing things, and there's no sort of standard way of doing that. I think, looking into new potential risk factors like intestinal permeability or the microbiome or other features that might be different in those who have this high body burden of osteoarthritis versus a single site or one or two sites is really important, and is underway both in our group and among others. And then just back to my acknowledgements, I've been privileged to receive funding for many of these studies. We have a wonderful team here. My initial mentor and the founding PI of the Johnston County study, Dr. Joanne Jordan, who I owe much to, Yvonne Golightly, my co-PI on all of this work, our staff and participants who have given their time and effort and much of their careers, in fact, to this study, our various trainees and collaborators and funders. Thank you.
Thank you, Dr. Nelson. That was a really great presentation. For those of you in attendance, feel free to type any questions for Dr. Nelson in the chat, and I will read them aloud as we have time. We do have one question here, Dr. Nelson. Are you enrolling individuals in the new JOCO cohort by biological sex or gender or both?
Yeah, so we enroll everyone, but we ask them to self-identify so that we can categorize based on the analysis, right? So if we're doing a behavioral, socio-behavioral type cultural analysis, then we want to be sensitive to that. So we do ask people how they identify. But if we're doing something where it's a biomarker or a bone shape issue that we know is directly related to biological sex, we also have that information. So we ask it both ways.
Thank you. One question I had was, I know you talked a little bit about race and you mentioned weight at one point, but are there any factors that might make someone at greater risk for multi-joint OA versus just being affected by one joint?
Yeah, I think there probably are. I don't think we have a great handle on that. So certainly there are some genetic factors, and there was a really well done study by Cindy Bohr and colleagues that identified some genetic markers that were associated with multi-joint osteoarthritis versus single joint OA. I think, if someone's had a clear injury history and maybe they have post-traumatic osteoarthritis, they're more likely, although not exclusively, to have a single joint involved, right? So if they've had a meniscal tear and an ACL tear in one knee, then they're likely to have knee OA, but they may not have the risk factors that would lead them to have multi-joint OA. For traditional generalized osteoarthritis, thinking about multiple hands and having nodular changes in the hands and maybe a knee or something, those tend to be older white women for whatever reason. We don't really understand, but that's how it was initially described. And that's how often it's thought of, which is part of the problem, because then we miss people who maybe have different patterns of multi-joint OA. And so that's part of our search to identify those risk factors and find people that have a high burden of OA.
Here's a comment and question. Great talk. What would be your recommendation on how to optimally account for multi-joint OA in clinical trials?
Yeah, I think the first step is just thinking about it, right? So a lot of our measures, whether it's a biomarker that we're pulling from blood or synovial fluid or urine, or it's a functional assessment that asks people about daily activities, those things are going to be affected by other joints besides just whatever index joint we happen to be interested in. So I think the first step is just thinking about that and at least asking about it. So getting maybe a symptom score or a homunculus that sort of says, which joints do you have symptoms in, maybe severity in those symptoms. I don't think we're at the point where we have to, radiograph every single joint. We can make a lot of these diagnoses clinically, but thinking about it, considering whether it's going to mask any effect of the intervention versus something that we could include but then address later on in the analysis. But just taking it into account is really the first step.
That's great. I'm going to go ahead and launch a poll here. If there are any other questions, feel free to type them in the chat while I'm doing this. And Dr. Nelson, we really appreciate your time and expertise. That was a wonderful talk, so thank you. And thank you to everyone in attendance today. We hope that you will join us in 2024 as we continue our Lunch and Learn series. We'll continue to meet on the third Wednesday of each month at 12 p.m. Eastern Time. So I don't see any other questions, so we'll end there. If you have time to take the poll before you leave, we'd appreciate it. Otherwise, we hope you have a great rest of your day. Thank you.